Hello, everyone. I'm here with Mr. Frank Mugisha, a seasoned international development expert, a global health marketing and communication professional, all the way from Uganda. And we're going to be talking on a lot of things, especially in the AMRS aspects, and trying to basically focusing on solutions, how we can bring solutions to Africa. Now, this episode is going to be going to a lot of public health and global health practitioners all over the world. So we hope that if you're listening and you have the ability to bring in some solutions based off of what me and Mr. Frank discussed today, or you'd like to reach out to Mr. Frank, definitely get in touch with us and let's see how we can create a better world in healthcare. So once again, welcome to the Healthy Public Health Podcast. So just a brief introduction on you, sir. I see you have a lot of experience with global health marketing and communication. For the past 12 years, you've been in health promotion, health communication, supporting projects, supporting organizations in the design and M&E, that's, for those who don't know, monitoring and evaluation of a lot of innovative projects. And that's really, really, really amazing. That's really amazing. You've seen. I know you've been a safeguarding manager for PMI Evolve Uganda project. How was that?
Yeah, of course, I left PMI Evolve recently in July, and
yes, sir.
we had a lot of work we did for the eastern part of the country that has been having challenges with malaria control.
Yeah.
It's one region that has epidemics, high epidemics of malaria burden.
Wow.
Which has claimed a number of children. And we even had a lot of black water fever, a type of malaria that also was rampant in the region, killing a lot of children. And in some districts like Chibuku, they actually thought it was due to witchcraft. So as a communication person, I have worked to change the myth and misinformation around that type of malaria.
Malaria, wow.
Which was also caused by malaria-causing mosquitoes. By designing strategies that really resonate with the culture, health communication strategy and the norms and communities, and also improve the system of tracking down communication.
Yeah.
Because you realize that community engagement is one area that is hard to measure.
Yes. Yes.
Also the hands of local leaders.
Yes.
Key stakeholders. Mm-hmm. Sometimes are not even politicians who may not be very much accountable.
Yes.
Getting
and also
reports
not interested.
From them.
Yes, sir.
Yes, and we had to do a lot to design. I designed what they call the wheel of practices for malaria-free smart homes.
Yeah.
Not everyone wants to have what does a malaria-free smart home looks like.
Yeah.
And so we, together with communities, we designed a set of indicators that define a malaria-free smart home.
Yeah.
A malaria-free one that sleeps under a mosquito net.
Yeah.
One that plants mosquito repellent plants.
Yeah.
As the world was ushering into the climate change movement.
Yeah.
We're already talking about climate change and malaria control by promoting tree planting in areas which are swampy, communities living in lowland areas. And these plants not only are just providing shade, but they are also providing protection against
mosquitoes. Wow.
And some of these were edible. We use some of the plants like neem tree when taking tea in our homes. So
and neem
you have double protection and nutritional benefits.
Yeah, and neem also helps a lot with malaria prevention, even internally. Yes.
We did that.
Yeah.
And of course, we encourage that the community health workers do visits. Monthly visits. We had to track them visits and hang the wheel of practices for malaria-free smart homes. We had a chart designed into a wheel, measuring practices that they do, they don't do, Like, for example, checking for malaria oftenly, attending ANC, because you know how malaria can really lead to mortality, miscarriages in pregnant women and all that.
Yes.
So we're also having a maternal child health component in malaria control.
Yes, sir.
And of course, ensuring that because this was a program that designed to talk about promote indoor residue spraying. Would make sure that the entry point into a malaria-free smart home is accepting indoor residue spraying. Was a number one condition for you to have for a home to be enrolled in a malaria-free smart home program. Must have previously resisted IRS, because then wouldn't want to preach the message to the already converted ones. We need to target those who are not converted and bring them into the healthcare, into the center of the equation, into the center of the malaria control equation.
So which is harder,
and we did that,
people who already have knowledge, or those who are just or those who are not yet converted, as you would say?
Yeah. And those were our entry point into the malaria free smart home.
That's beautiful.
So after that, we have done a number of interventions in range beyond malaria control, NTD, like you've seen in my profile of LinkedIn, maternal child health, immunization in the country.
That's beautiful work.
At one time, I also studied from the University of Ghana, and I had a lot of friends from Nigeria. I think I had a roommate who was a Nigerian roommate.
That's one thing we have in common then. We both been to Ghana. I didn't know that.
I was in Ghana before, at the University of Ghana.
University of Ghana, that's in Accra.
Legon campus.
Accra, yes.
I was there before, and of course, I've also studied from the German.
Germany.
That is Technical University of Dagendorf. Been able to do masters in global public health from there, and currently I'm doing a global public health PhD from Euclid University online.
Yes, I was going to bring
love
that
online education because it gives you the skill, and you implement everything you learn in class. You go and practically apply it as you go on the go.
Yes, I was telling someone that if
so I was able to participate. I was able to participate actively in the COVID-19 control interventions in Uganda while doing an online master's education. In Germany. Because that's when European universities open doors online education. For people who could not travel there physically, who would be challenged with visa and immigration requirements, expensive challenges. But we are able to get this knowledge, and we are proudly implementing this acquired knowledge. This today's topic of global causes of death and how we can leverage community health structures to really improve detection, prevention, and control of diseases that would actually, actually would have been preventable, but are still a challenge on the African continent.
It's still a huge challenge. And that even brings us to all the questions we have right now. For those who don't know, for those who don't know, Mr. Mugisha has been a senior consultant at the Masuli Center for Health and Behavioral Economics. He has been worked on that project, and also worked before that. He worked as a technical advisor and consultant at SBC, working on regional health integration to enhance services in northern Uganda. So he has a really, really extensive profile. So when he speaks from a point of authority on the healthcare aspect in Uganda, especially when it comes to primary healthcare, working with the individuals, understanding the situation on ground. And that's really, really beautiful. So let's go into the first question. Oh, please give me 1 second, sir. Let me get my charger for my laptop. I'll just put it on pause for a second. Thank you. So now let's take a look at the first question. When we were talking some days ago, I realized you are very passionate about community health extension workers. And that's one thing that people rarely talk about, the burnout that they face, the fact that it's so easy for health workers to become the what's the word again in healthcare, whereby they become depersonalized from the situations they face due to constantly facing those things daily. And people never really talk about that or how important it is. And so how do you think a modern health extension worker in a community system, in a community, how do you think systems set up for them should be structured in a way that would meet today's public health challenges, especially in the low resource settings, which we have all over Africa? What's your take on that?
Well, a strong community health extension work system can be the backbone of primary care in low resource settings like Africa, non-African countries.
Yeah.
Especially when it is designed for simplicity. For accountability and continuous learning.
Yeah.
The key is to formalize the laws.
Yeah.
Here you talk about formalizing the laws of community health extension workers.
Yes, sir.
That they are clear. To standardize supervision.
Yeah.
For any country to really have a strong community health extension work system.
Yes, sir.
Connect community action to facilitate best care.
Yeah.
Because there must be a very strong linkage component. And without creating a lot of bureaucratic burden.
Yeah.
That is normally associated with our community, our facility-based care systems.
Yeah.
Where you don't see a doctor before you go to the lab.
Yeah. It becomes a bottleneck. A bottleneck that reduces the effectiveness.
Police.
Yes.
The bottlenecks.
Yes, sir.
And of course, so on the design, the core law design for the extension workers system. One is you should focus on the choose should focus on prevention, promotive, and best curative tests aligned to national policies.
Yeah.
So whatever treatment policies that we have, let's have a replica of that at community level. And how the community can come in to manage this, whether in HIV, whether in malaria control and prevention, TB, maternal child health, the vaccination and immunization, name it. And when you to do that, you must have task shifting protocols.
Yeah.
How would the choose come in? If you're designing an MR prevention system, and we have pharmacies in the community selling drugs, drug stores at community level.
Yeah.
What is the community law in regulating, for example, antibiotic resistance?
Yeah.
In such a setting, and this, of course, with the trained choose who are easily supervised, task-based supervision and targeting. Yes, would be key in ensuring that some of these interventions really become fruitful and sustain some of the gains that we would want to see in healthcare.
Yes, sir.
There must be clear referral pathways to the nearest health facility amongst VHTs and the community health extension workers. In Uganda, these community health extension workers are actually at the parish level and supervises the VHT structure at the village level. Synchronized both at parish and sub-county level, where now we have health assistants.
Oh, wow.
The health assistants should be able to fit into the picture, and maybe public health nurses.
Yes, sir.
Now there is tired deployment.
Yes, sir. I'm sorry, I have a question. When you say
so that is a design that we have in Uganda, and we think
we have to
if strengthened,
we definitely
can actually serve the whole continent.
Yeah, we have to talk about that. When you say on a parish level, do you mean like parish in church, or does that mean something else in Uganda?
We have what they call assemblies.
Assembly, okay.
A community assembly, which is a village, headed by what in Nigeria or Ghana they call an assemblyman.
Yeah.
Here we call them LC1.
Okay.
Their persons. Local village.
Yeah.
Within that village, within the village, we have according to kinship zones in each village.
Okay.
Each kinship zones. These are zones of people who maybe use one water source, a shared water source.
Shared water source.
Or they have common relationships.
Yeah.
Common neighborhoodness. Or sometimes they are related to one another. Maybe it's a big clan.
Okay.
Marrying from each other, some intermarriages between them.
Yeah.
And an extended family in some areas.
Very interesting.
Now, the other part of a strong community health extension work system is tiered deployment. A tiered deployment is, here we mean assigning choose to define the catchment areas with case load norms.
Yeah.
So you tie you deploy the community health extension workers in a defined community extension community catchment areas, geographical areas, so that no one feels overworked.
Yeah.
They have shared workload,
responsibility, yes,
and linked to health facilities for supplies.
Yeah, and the work is equally
and then
distributed.
They are properly linked to health supplies, to health facilities for medical supplies and data handover. Yeah. Because whatever they do, it is not yet done. In M&E, we have a saying that it's not done until it is reported. Yeah. So if community health systems must function, reports must be coming in. I'm happy that our government, through support from partners, they are giving the newly trained community health extension workforce iPads, which are going to help them report timely. As you visit the home, and this drops actually will be brought to GPS enabled. Yeah. So that you actually, when you say you visit home X, you are actually there.
You're actually there.
There is a lot of proof that you are in that home.
Yes, and so even when
as you log into that person, details into the system,
it all comes
linked to the national ID. So the information immediately goes to the ID, the national database DHIS2 system of the country.
Yeah, that's beautiful. It's beautiful.
And of course, the districts will have access to those databases, and they can see. And at the end of the quarter or a month, it is easy to know how many homesteads we have visited, and of which age group, which age, gender, and what are the conditions this home is facing.
Yes, sir.
And so you can design public health interventions, messages, using data that is real time, and verifiable.
Yes, sir. Speaking, holding that,
and of course,
I'm so sorry. Holding that thought, since we are currently talking about interventions, what?
Yes.
Outside of this also, and this is beautiful. Do you, just so we don't miss out on the other one, on other solutions you may have? I want to pick your brain a little. What other practical low-cost strategies that do you think can be adopted either by government, by practitioners? They have to be realistic low-cost strategies that can actually help reduce things that are happening, that can help with retention of chews, and even at the same time, that can be adopted to reduce things like, for example, antibiotic misuse, in a way that outside of regulations, everything still works very well, because we both know that in Africa, regulations are usually just merely there. They don't really solve the problem. But things like what you've been talking about are what would solve the problems.
Well, talking about regulations, really, we are living in a free society.
Yeah.
The world is really, and there is a lot of information fatigue, if I can say, from different sources. A lot of social media is providing a lot of, I think we are in the IT revolution.
Yeah.
There's a lot of information out there.
Yes.
And countries are now in a situation where they have to really ensure that every authenticity of every information that is out there, demystifying the myths that come in form of facts. And so one area to improve, to remove this kind of bureaucracies, information fatigue and competition, is that we must first of all standardize training and competences for the community health extension workers.
Yeah.
Now in Uganda, this has been done, but I think the focus on AMR, antimicrobial resistance, and was not so strong. That's an area that should need to be developed in the future training modules for community health extension workers in Uganda and beyond. Building mentorships and support supervision structures. This is an area for routine and actually even during outbreak responses.
Yes.
When it comes to data and accountability, if we can develop simple paper-first registers with monthly digital aggregation by facility focal persons, to tune performance dashboards for community structures tied to supervision checklists and feedback loops at district level. Sometimes delays in feedback to community health interventions, where to fill in the gap is I think in most counties still working.
Yes.
Supply chain and logistics, and essential commodities like RDTs, or RS and zinc, family planning, PPEs, and educational materials. Repositioning of community kits at facilities with quarterly stockouts. Now, a number of countries, including my own, have attempted to retool community health extension workers and the VHTs in that manner in silos, maybe Bendistone, partners. So there is we need to standardize a kit for community health engagement, standardize educational materials, and how we preposition these kits, how we proposition the kits, and what kit content should be standardized as well.
Yes, sir.
And then with quarterly audits to not only to check on stockouts, but also ensure proper use.
Yes.
And then on the side of community engagement, we need to formalize partnerships with local councils, faith leaders, women groups to create demand for healthcare demand. Of course, positive health practices, including AMR awareness, and of course, promote social accountability around service quality and responsible antibiotic use.
Standardization is the perfect word for everything. Standardization and checking.
In summary,
yes.
So in short, a modern, prosperous, and progressive community health extension work system should be modular.
Yes, sir.
Tied to the anchored to facilities. With standardized competences for both the trainees, the people you recruit. And in terms of deliverables.
I believe so much in standardization.
Supervision.
Yes, sir. I believe so much in standardization that I named my company Standard. Standardization works very well.
We have tools that you can even speak to when you come to Nigeria. So some of the conditions are the same across countries in Africa.
Very true.
Some of the diseases that disturb Uganda,
they disturb
Nigeria. Kenya, Tanzania.
As long as especially
Nigeria and the rest of Africa.
Especially when the climate is similar in those areas.
Especially when the same climatic conditions.
Very
good to pull out that. So the simple data tools, formal community partnerships, best meets current challenges in all resource settings.
Thank you very much. Once you confirm a system is working, you get a working system and you just replicate it everywhere. So that we have just 7 minutes left before Zoom is going to reset the timer and we'll be logged out. So thankfully we have just about 2 questions left. So I'm just going to throw some rapid fire questions at you at this point. So I want to ask, is it realistic? Because I know you have a lot of interest in antibiotic stewardship. Is it realistic to enforce antibiotic stewardship at the community level with community pharmacies, drugstores? And do you think it works? Do you think it's realistic and it would work?
Yeah, it can work. For example, community strategies that I would suggest that for it to work,
yeah,
there's community strategies to reduce antibiotic misuse without relying on regulation would include, first of all, we should appreciate that communities can every curb misuse of antibiotic use through norms, education, practical alternatives, and that make not using antibiotics. Irregular misuse of antibiotics. And they continue to feel safe and doable.
Exactly.
Now, the actionable low-cost steps that I could do suggest would be like sick day plans. If we can, the healthcare system can give out household cards that try in first steps for common illnesses like flus, ORS, fever management, and red flag referral signs. So that if you are able to know the referral signs, the danger signs, where now communities do not treat themselves and need to refer for formal health care, help families avoid self-medicating with antibiotics for viral illnesses. Have trusted messengers in place, train local leaders, teachers, and religious figures to normalize antibiotics only when needed. Because that's the catchword you should have. Antibiotics only when needed. Making it a shared community value rather than a rule.
So
the slogan antibiotics only when needed slogan campaign would be a very good catchword for promoting reducing antibiotic misuse.
Thank you.
So that the culture, it is culture that antibiotics should not be used and only used only when needed, and based on prescription from a qualified healthcare provider.
And even the
healthcare professional, we can put up. At community level, we can have symptom triage stations. This is something that we have not been doing previously. So periodic outreach days for quick assessments and counseling, reducing pharmacy first behaviors for self-limiting conditions. So we can have, just the way we run immunization campaigns, we can have symptom stations in communities by reducing the distances. But because what prompts communities to go and buy antibiotics in nearby drug shops? Because maybe the health facilities are far off from their reach. And so the cost involved in transporting a sick child from home to the facility makes is higher than walking into a nearby drug shop
and
purchase an implied antibiotic that is likely to treat this condition. So, but when you have these symptom triage stations and happening maybe bi-weekly, where you do an outreach, which is general clinical outreach for all conditions. Actually, we limit.
It will limit misuse a lot, and I also feel
story-based campaigns.
Even the community the health pharmacists should also be held. They should be held up to a stronger level of liability when to make sure that they are able to keep things in check. In, for example, the trials.
Supervision, the pharmacists could help us check on these drug stores.
Thank you.
The condition the antibiotics they prescribed sold out. Whom they sold it to? What was the condition?
They should be able to keep those data and be able to present
whose prescription did they use to issue it? One time I went to a pharmacy myself, some time ago. Long time ago when I was a child, and I wanted to buy some antibiotic, and there was this white nurse who was working in this pharmacy in Kampala. And they asked me for a doctor's prescription. And when I didn't have it, she never sold me the drug. And this drug had been sent to
Yeah, and that is what should be.
I had been sent to buy this drug by my father. So up to now, I still remember that nurse.
Yes, and those are standardized.
20 years ago. Just because she refused the money.
Yeah.
She refused the money because I didn't have a doctor's prescription.
And that's a good thing.
We have such kind of nurses today in our facilities.
Everywhere. People are more to compromise these days, and it affects. That's the reason why there's so much substandard drugs and wrong drug use everywhere.
They seem to be rushing to make a sale.
Yeah, exactly. They care more about the sale than the actual long-term impact or even short-term impact of the drug on the person.
The long-term public health effects.
Yes, and even how it affects
rational antibiotic use.
Yes. We have 2 minutes left, finally. So I want to ask you one question. And if you can make the answer just one sentence, because the timer is going to log us out in less than 2 minutes. You have a lot of interest in health insurance, community-based health insurance. So if you can just in one sentence tell me, do you think it's a sustainable model, or do you think community health? I know it's going to be hard to do this in less than 1 minute, but do you think community health-based insurance is a better model than what currently exists, or no? Just one sentence, sir.
Yes, community-based health insurance can expand access, accountability locally, but struggles with equity, scale, and financial protection. Sustainable universal health care generally requires substantial public financing and oversight. Yeah. And yes, community-based health insurance should not be a standalone to universal health coverage, but can be useful as a bridge to complement equitable coverage, but requires substantial government funding and regulation. Yeah. I've seen countries that have attempted to provide community-based health insurance, and
it failed.
They rely on tax-based or mandatory social health insurance. Yeah. Sometimes by deducting monies from people who are already working. Okay. But yes, it is very good, especially for targeting young children and the elderly. Yeah. Those who cannot afford. Yes. It brings and for every health insurance model, I think the key to successful health insurance is by educating people about how positive lifestyles. Yes. Lifestyles. Thank you. Lifestyles.
Thank you so much.
So that we save more money and keep it for those who really need it most, for conditions that we cannot prevent. Exactly. Like a road traffic accidents. Yes, sir.
Yes, sir. I think that's a beautiful note to end this episode, and we really should look more into it. If you are a health practitioner in this field and you have interest, I'll be leaving Mr. Frank Mugisha's LinkedIn profile on the bottom in the description of the video, and you can reach out to him. So thank you so much, sir, and it was a pleasure having you.
Yes, they are all welcome.
Thank you so much.